Okay, talking about aesthetics and soft tissue, when we talk about treatment strategy, it's important to realize we have different options, and it's one of the most important steps to make these bioaesthetic considerations before you start with the treatment. Sjoerd also showed us a very nice lecture on decision making earlier this day. So, when we talk about these considerations, we work with components, and one of the most important components is what you see here. It's the bone. And the bone is not only the anchorage for the implant, it's much too simple as a function we give to bone. Of course, the implant has to go somewhere, and the implant will go in the bone, but the bone itself is also our soft tissue framework, and this is a very important function of the bone, the way I see it. To summarize things we already heard, is that after extraction we will lose an important part of the buccal bone within the first 3 months. And you can see here, especially in this aesthetic zone, the buccal bone is very thin, and this is genetically determined. So this is what I call a double trouble, because we are having thin bone and we were working in an aesthetic area. And George already showed us what can go wrong also if you don't focus on this before you start. On the other hand, more distally in this area, we have thick and strong bone. But there we don't really need it because aesthetics are less important. So this is not really fair for us as clinicians. Good. Well, our goal is to place our implants in the bone, and if the buccal bone is lost, as you see here, we have to do something. I place my implant slightly palatal, and that's the 3D implant placement. And we already know that it's wise, especially as George told us, if you have bone resorption because of the biologic width, which is going to establish here, we need at least 2 millimeter bone, and it's not bad at all to over contour this area a little bit. So this is a predictable way of building up bone if we need this. I use the GBR technique, autogenous bone combined with a non-resorbable membrane, which is, in my opinion, still the state of the art in these big defects, as you just have seen underneath this membrane and the bone graft. And then you can see here during the closure that even if you are able clinically to recreate thick bone, and buccal bone as well, this is really not enough. 7 months down the road, you can see there is a thin biotype. And we heard this already before. Having just the underlying bone, even if that's enough to cover the implant, it's not enough. We also need the thick biotype. The soft tissue envelope has to be adequate. And so soft tissue component is really important, as the underlying bone is important. What we learned is that after an extraction we will always lose up to 1.5 millimeter, so 0.5 to 1 millimeter of recession is normal because we have a healing wound. And this has to be taken in consideration whenever we do an extraction. Only 15% of my patients, they start off with a thick biotype. So also here we have a problem. And I agree with the previous speakers that in most cases I will have to do something to rebuild thick biotype. So I'm going to boost the biotype because thick tissue means easy aesthetics, and we all agree about this. And this is what we want. Thick periodontal biotypes, and this is what we most of the time will have, the thin periodontal biotype. So we know all what it means in tissue high and scallop papilla, triangular teeth, and very easy recessions, and you can see it also here. And that's true for every type type of dental procedure you're going to do on these natural teeth. And on top of that, we need 2 papilla as well. And we talked already about the papilla and the importance of building up these papilla. And Martijn Molenaar and Erik, they showed us this morning how they carve the soft tissue, how they give what I called adequate prosthetic support to keep this complex 3-dimensional architecture in place and to keep it stable over time. So this is basically what I consider as important key factors if you want to work in an aesthetic way with all these components. So if we limit ourselves to single tooth replacement, the strategy is important, the buccal bone, the papilla, the abutment crown combination. Nowadays we have a wide choice of aesthetic materials. We can still use titanium, but zirconium and alumina are very often used. And when do we have to go for these metal-free solutions? I will give you some brand new data on that as well. The best strategy. Well, we have 3 possibilities. We can preserve, we can reconstruct, or replace. Replacement means, for me, working with pink aesthetics, so pink porcelain can be an option. As I limit myself in this lecture to single tooth replacement, most of the time I will be able to completely reconstruct the missing tissue, so replacement is not an option. I don't work with pink porcelain in single tooth replacements. So these are the 2 options, preservation and reconstruction, and I will give you now some clinical examples. Preservation and reconstruction of what? Well, that's easy. That's basically the bone, the soft tissue, and the adjacent teeth. These are the players in the game. And they are all related, and it's all about finding the right balance between bone, soft tissue, and prosthetic support. These are the main components, and they are all related. And working with these components, for instance, some very small details can make the difference. A small step, but very important, is the provisional phase of the treatment, for instance. And I will show how we work with these components. Let's start with an example of a clinical case, and of course I will repeat some of the information you already heard. This is an example of preservation because the implant is over here. We did a post-extraction case. This is the implant, supported prosthesis, post-extraction case. The soft tissue was enhanced orthodontically by pulling the tooth, the fractured root, down by extruding it in order to gain some extra soft tissue. We want to have a soft tissue surplus, as George so nicely mentioned before me. And here we did a metal-free abutment and crown combination. I will show you, this is the fractured root. This is a very simple homemade orthodontic device. Aesthetic for this patient was not very important at that stage. So it's important that you extrude. Actually, we don't want buccal tipping of the root, because we will lose buccal bone, and this can make sometimes things worse. So it's very important that the root goes down straight. And if you have a tooth or a temporary crown on top of a root like this, be careful with the occlusion. The patient has to come back and we'll check the occlusion, because also occlusal interference can cause resorption of the buccal bone. And then you can see that the tooth comes down, the elastic band is touching the bracket over here, so we gain soft tissue. And you basically never have enough soft tissue.
For more education programs, visit the GIDE Institute at www.guidedental.com.